Hello, my name is Ji-Soo, an assistant professor in Pediatric Dentistry, Seoul National University. It's my great pleasure to give this lecture, and I really appreciate you for being with me. I'm going to talk about some basic concepts in the primary and mixed dentition in my 3 lectures. This is my first lecture, and I'm dealing with occlusion and space in primary and mixed dentition. I have divided this presentation into 3 parts. We are going to look at the pattern of occlusion first, and then we will discuss about spaces in primary and mixed dentition, followed by developmental pattern of dental arch. First, let's look at the pattern of occlusion. The pattern of occlusion is consistent in most cases. As you all know, there are no teeth clinically at birth except for natal tooth. And intercuspid width of upper gum pad is typically wider than the lower pad. If you look at the overjet, upper anterior gum pad usually protrudes 3 to 5 millimeters compared to lower anterior gum pad. In the first 6 months after birth, palatal width increases significantly and the overjet decreases rapidly. In terms of overbite, we can see interocclusal clearance in anterior region and upper and lower gum pad only contact in the site where first primary molar erupts. The first primary teeth, usually mandibular primary central incisors, start eruption around 6 months of age, and most of primary teeth appear for about 2 years. By 3 years of age, the occlusion of 20 primary teeth is usually completed. Thereafter, primary dentition is maintained until around age 6. Around age 6, permanent first molars and mandibular permanent central incisors erupt, and mixed dentition lasts for about 6 years with both primary and permanent teeth. After completion of primary dentition, the relationship of distal terminal planes of opposing second primary molar teeth can be classified into one of 3 categories. In the flush terminal plane, the anterior-posterior position of distal surface of opposing primary second molar are in the same vertical plane. In the mesial step terminal plane, distal surface of lower second primary molar locates mesially to distal surface of upper second primary molar. In the distal step terminal plane, distal surface of lower second primary molar locates distally to distal surface of upper second primary molar. Mesial step terminal plane is more frequent in Asians, and the distal step terminal plane is more frequent in Caucasians. The canine relationship is also classified into one of 3 categories. In Class 1 relationship, cusp tip of maxillary primary canine is on the same vertical plane as the distal plane of mandibular primary canine. In Class 2 relationship, Cusp tip of maxillary primary canine is mesial to distal surface of mandibular primary canine. In class 3 relationship, cusp tip of maxillary primary canine is distal to the distal surface of the mandibular primary canine. After eruption of permanent first molar, relationship of opposing permanent first molar can be classified into 4 categories as shown in this picture. Class 1 relationship means mesiobuccal cusp of upper permanent first molar is in contact or very near the buccal groove of the lower permanent first molar. End-to-end relationship means that mesiobuccal cusp of both molars oppose one another. Class 2 relationship is one in which an upper mesiobuccal cusp is anterior or mesial to the lower mesiobuccal cusp. Class 3 relationship represents the situation in which an upper mesiobuccal cusp is posterior or distal to the lower buccal grooves. The most desirable occlusion in permanent dentition, of course, a class 1 relationship. Gum pad relationships before primary teeth eruption cannot be used as reliable diagnostic criteria in predicting permanent dentition relationship. However, by 3 years of age, the relationship between maxilla and mandible is well established, and the overall occlusal patterns does not change significantly thereafter. So, ideal occlusion at a young age predisposes to an ideal adult occlusion to a considerable extent. Certain relationships in the primary and mixed dentitions can provide clinical clues as to whether a class 1 relationship will eventually develop. So, terminal planes of primary dentition have diagnostic potential regarding future occlusion. Let's see the change of occlusal pattern from primary dentition to permanent dentition. If a child shows distal step terminal plane, it is unlikely that class 1 molar relationship will be achieved in permanent dentition. The presence of distal step is highly predictive of developing class 2 permanent molar relationship. Children with flush terminal plane can develop class 2 end-to-end, class 1, and class 3 relationship in permanent dentition. When a child shows mild mesial step terminal plane, there is a high probability that class 1 molar relationship will be achieved in permanent dentition. In case of exaggerated mesial step, a class 3 molar relationship will develop. We can also predict future occlusion using relationship of the first permanent molars during initial occlusal contact in early mixed dentition. In case of distal step, permanent first molars show class 2 molar relationship at initial occlusion contact, and it will remain a class 2 molar relationship in permanent dentition. In case of flush terminal plane, end-to-end permanent first molar relationship are shown in initial occlusion contact. And 75% of cases will shift toward class 1 relationship in permanent dentition. but the remaining 25% will shift into a class 2 or end-to-end relationship. When a child shows class 1 molar relationship at initial occlusal contact, it is possible from flush terminal plane or also from the mesial step, the patient is more likely to have class 1 molar relationship in permanent dentition. A class 3 molar relationship at initial contact will probably lead to a future class 3 relationship. The occlusal relationship remains nearly the same throughout the growing period, but in case of premature loss of primary teeth or parafunctional oral habits, such as finger sucking or mouth breathing, the overall pattern can be changed during the growth. For example, this patient lost the left maxillary primary second molar at an early age, and the left first premolar is showing distal tipping, and left permanent first molar has rotated and tilted mesially. So we can see the slight class 3 molar relationship in the right side, which is thought to be normal in her skeletal class 3 jaw relationship, but end-to-end molar relationship in the left side. Now let's move on to the second topic, space in primary and mixed dentition. Baum reported two consistent morphologic arch forms in the primary dentition: generalized spaces between the teeth or no spaces between the teeth. These types of arch were defined as Baum's type 1 and type 2 arch. These arch forms are congenital rather than developmental, and the original pattern exhibited at eruption was maintained from ages 3 to 6 years. Spacing between primary teeth has been accepted as a desirable one because of size discrepancy between permanent and primary teeth. In case of a Baum type 2 arch with no space between the primary teeth, the possibility of crowding in the permanent teeth is very high. Because the differences in teeth sizes between primary and permanent dentition is greater in maxilla than in mandible, crowding is also more common in maxilla than in mandible. And if a child has no interproximal spaces, there is high probability that he or she is in high risk of interproximal caries, so active caries prevention should be recommended. Spaced arch frequently exhibit two types of space, referred to as primate space and developmental space. Primate space is indicated by red arrows, and it means the space between the maxillary lateral incisor and canine, and the space between mandibular canine and first molar in primary dentition. Developmental space is indicated by blue triangles, and it means interdental spaces between maxillary and mandibular anterior teeth. Before the eruption of a permanent first molar, the dimensions of a primary dentition usually remained unchanged. but in case of interproximal caries or early loss of primary teeth, the space can be decreased. And there is a latent space that appears because the sum of mesiodistal widths of primary canines and primary molars is bigger than that of permanent teeth. This latent space is called leeway space. Because mandibular second primary molar is much bigger than mandibular permanent second premolar, leeway space is also bigger in mandible than in maxilla. In average, leeway size difference was 1.7 millimeters per side in mandible and 0.9 millimeters per side in maxilla. This leeway space may offer opportunities for significant improvement in mild tooth size and arch size discrepancy. With space supervision using space maintainer, we can relieve mild crowding in lower anterior, and we can avoid unnecessary orthodontic treatment. Between the eruption of permanent first molar and the eruption of permanent canine and premolars, the molar relationship can be changed using spaces in primary dentition. In case of flush terminal plane in primary dentition, first permanent molar can move mesially and develop class 1 molar relationship by two types of mesial shift. First, during permanent molar eruption, the permanent first molar can move mesially by pushing primary molars to mesial side and consuming primate space. This type of mesial shift is called early mesial shift. This early mesial shift is not desirable in most cases because it is better to use primate space to improve the interior alignment. The second type of mesial shift is late mesial shift. Late mesial shift occurs at the expense of the leeway space. Late mesial shift allows the anterior teeth to be aligned using primate space, so it is usually thought to be desirable. If we block the late mesial shift using lingual arch, we can use more spaces to align anterior teeth. But in case of class 2 or end-to-end relationship at initial occlusal contact, blocking the late mesial shift can cause class 2 molar relationship in permanent dentition. And this approach might cause disturbances in the eruption of permanent second molar, which erupts in late stage. So careful follow-up is needed when space-maintaining device is used. Now let's look at the last topic. Usually, the sequence of dental development and eruption is almost the same for everyone. For example, the dental hard tissue formation and eruption of mandibular teeth is usually precedes those of the maxillary teeth. And in primary dentition, all the primary teeth begin their formation during pregnancy. And the first primary tooth to appear in the oral cavity are central incisors, especially mandibular central incisors. In the permanent dentition, dental hard tissue formation does not begin until after birth. The first permanent molar is the first tooth to show evidence of calcification and to appear in oral cavity clinically. Usually, permanent second molar erupts last, except for permanent third molar. In primary dentition, the usual eruption sequence is the central incisor and the lateral incisor, the canines or the first molar, followed by the second molar. The eruption sequence of the canine or the first molar is sometimes reversed in primary dentition. In permanent dentition, first molar erupts first, but sometimes central incisor can erupt before first molar. In the usual eruption sequence, permanent second molar is the last one to erupt except for third molar. And permanent canine usually erupts before premolars in lower arch and usually erupts after first premolars in upper arch. Let me show you some clinical cases. This patient was 5 years old and he showed normal primary dentition. But the second patient was also 5 years old, but we can't see his right maxillary primary second molar. In his panoramic radiograph, the right second primary molar is located within the alveolar bone. After we had CBCT taken, we was able to find a small radial opacity that had interfered the eruption of the tooth. Compared to the permanent dentition, there is relatively less variation in the sequence of development in the primary dentition. So, if any primary tooth doesn't appear in oral cavity even after age 3, radiographic evaluation might be necessary to detect any abnormalities. This patient was 8 years old and maxillary right central incisor didn't erupt, and the left central incisor and right lateral incisor have already erupted. The eruption space for the right central incisor was decreased. In her panoramic radiograph, we could find a supernumerary tooth between the central incisors, and the eruption of right central incisor was delayed because of the supernumerary tooth. So, to guide the eruption of the central incisor, surgical removal of supernumerary tooth and additional orthodontic treatment were necessary. Let's see another case. This patient showed two supernumerary teeth in anterior maxilla, and right central incisor was deviated from the normal position. After surgical removal of the supernumerary teeth, and the central incisor erupted normally without any surgical or orthodontic treatment. So, if a dentist wants to prevent any eruption problems in early mixed dentition, radiographic evaluation, especially panoramic radiograph, is strongly recommended before age 6. I will show you some more cases. This patient was 9 years old and mandibular right permanent first molar didn't erupt, and we can see a small radial opacity above the impacted first molar. In CBCT images, we can see the small radio opacity in a radiolucent lesion. So the lesion was removed by surgical procedure and it was found to be a benign odontogenic tumor through pathological analysis. With the removal of a benign tumor, surgical exposure and button bonding were done for orthodontic traction. Usually, young patients can't endure surgical procedure in the posterior area, so all procedure was performed under general anesthesia. We can see the exposed traction wire in the normal position of the first molar. After surgery, a modified non-solding arch was used to pull the impacted molar upwards. The patient was asked to wear elastics between the buccal tube on the band of non-solding arch and the traction wire. Finally, the mandibular first molar erupted in the normal position. But if we catch any abnormalities in early stage, the additional orthodontic treatment and surgery such as window opening for orthodontic traction shown in the previous slides may not be necessary. In this 4-year-old boy, radio opacity is shown above the left mandibular first molar. In the CBCT images, we can also see the lesion in detail. Because the patient was too young to endure surgical procedure, surgical removal of radiopaque lesion was done under general anesthesia. The lesion was removed in time before the first molar began to erupt, so the tooth erupted normally without any additional surgical or orthodontic procedures. This patient was 13 years old and the permanent dentition was completed except for the both maxillary canines. We can see the over-retained maxillary primary canines and they didn't show any physiologic mobility, which is usually seen at exfoliation stage. Sometimes, even though there is no abnormal eruption sequence clinically, we need to take a panoramic radiograph to detect any problems in mixed dentition. In her panoramic radiograph, both maxillary canines were erupting in ectopic position, and the follicular spaces around the crowns of the canines were enlarged, so there was a possibility of cystic changes. Surgical exposure and button bonding on the canines were performed under general anesthesia, and orthodontic traction using braces was necessary. This patient was 10 years old and we can't see any eruption sequence abnormality. The maxillary primary canines exfoliated prematurely, and maxillary permanent canines and second premolars have not erupted yet. But in this panoramic radiograph, we can see both maxillary canines erupting in ectopic position. Unlike the previous case, the roots of the 3 anterior teeth were resolved too much. Because of the severe root resorption, we couldn't maintain the right central incisor and left lateral incisor. After extraction of those teeth, both canines erupted. So, if a dentist wants to prevent any eruption problems in late mixed dentition, radiographic evaluation, especially panoramic radiograph, is strongly recommended before age 9. After eruption of the right maxillary canine, it was restored with composite resin. Because she is still growing, the final orthodontic and prosthodontic treatment were deferred until growth completion. This is the final case. 10-year-old female showed ectopic position of the right maxillary canine. The root of the right central incisor was resolved, but the extent of resorption was not severe compared to the former case. So distal traction of the canine and maintenance of the central incisor were planned. After window opening and button bonding of the canine, distal traction was initiated using a fixed device based on Nansolding arch. You can see the traction wire here and the elastic engaged between the traction wire and buccal tube on the band of Nansolding arch. After canine moved distally, braces bonded to the whole dentition and orthodontic alignment is in progress. The right central incisor showed considerable root resorption, but in the final panoramic radiograph, we could anticipate good prognosis of the tooth. So again, if a dentist would like to prevent any eruption problems in late mixed dentition, radiographic evaluation, especially panoramic radiograph, is strongly recommended around age 9. Thank you for your kind attention. If you have any questions or comments, please let me know using my email address. I will do my best to answer each one. Thank you.